Hello and welcome everyone to our second podcast. Today we have David Warren, who is a year three nurse anesthesia resident at National University. He's my senior. Thank you so much, David, for taking out time from your busy schedule to be here. A lot of my friends requested this topic, your journey from a nurse practitioner to a nurse anesthesia resident into CRNA school. So I'm glad you could join us. So if you want to go ahead and introduce yourself.
Awesome, man. Thank you so much for having me on. I really appreciate it. My name is David Warren. I'm a third year nurse anesthesia resident at National University. I'm 6 months away from graduation, not that we're counting. It's been a really long 3 years, but super glad to be done here soon. So thanks again for having me on.
Of course, man, 6 months. Wow. You're almost done.
Almost there,
Almost
man.
there. Almost there. Wow. Well, let's just jump right into it then. So first category I have is career transition. So question I have for you is, can you tell us a little bit about your background as a nurse practitioner and what motivated you to make that switch from nurse practitioner to a CRNA?
Sure. Yeah, that's an excellent question. So it honestly started way back before nursing school. I knew that growing up, I wanted to do something in healthcare, and I grew up watching the medical shows, and I was fascinated with emergency medicine, and I knew that that was kind of the path that I wanted to take initially. And so I went into nursing school thinking that that's exactly what I wanted to do. I wanted to be an ER nurse. And I didn't really know anything more after that. I just knew that that was something that really fascinated me. And I made some really dumb mistakes at the end. And I'll kind of get into that here in just a second. So at the end of nursing school, again, I knew like going in from the start, I wanted to work in the ER. After graduation from nursing school, I was applying to ER jobs. This was back in 2012. There weren't a lot of ER jobs around at that time. And so I applied to what was there. And I also applied to some ICU positions, thinking that that may be where I would like to end up doing some critical care, and then eventually end back up in the ER if I couldn't get in the ER first. And so, again, there weren't really many ER jobs open. So I applied to a couple of ICU positions, and I got hired straight into the CV right out of nursing school, accepted a position. And I was also, again, applying to these ER jobs, and I applied to a level one pediatric trauma center in Dallas, Texas, got an interview, ended up getting the job. It was like a new grad nurse residency program for about a year. And I knew that was probably my into the ER. And so I ended up turning down the ICU position, going to the ER, which is what I wanted to do at the time. And really fell in love with ER nursing and emergency medicine in general. And I thought that that's something that I wanted to pursue for the rest of my life. And so I shadowed some nurse practitioners in the ER, really enjoyed that role. Also thought about medical school, but I really enjoyed the nurse practitioner role. And I thought that's where it's at for me. And so I applied and got into NP school, went to an in-person program at the University of Alabama, graduated a few years later with my master's degree, and then started working in the ER. And my first job was in an academic medical center, just doing a wide range and seeing a wide range of pathologies, really getting good career experience. And I've worked really anything from academic medical centers to community hospitals to critical access hospitals and even to remote and wilderness medicine, across the spectrum of my NP career. And so that's kind of how I started into the emergency medicine world. And I quickly realized about 3 to 4 years in that this may not be a forever job. It sounded really good on the outset. It looked really good. But for those of you who've worked in the ER, you know there's a lot of overutilization of the system. There's not true emergencies that show up every day. There's a lot of minor urgent care type stuff. People abuse it, and for appropriate reasons. The healthcare system is completely broken, so it's understandable. But it's not something that I wanted to do the rest of my life. I loved the emergency medicine and the critical care aspect of it, and patients that had true emergencies that I was able to reverse and to help and to correct and to get them admitted or to the appropriate destination. I love that and still love that. I did not like the other stuff that came along with that. And so I knew several years in that I needed to do something different. I wasn't sure at the time what that looked like. I thought maybe I'll go work in the ICU, maybe I'll go work in a specialty clinic or something. I really enjoyed the shift work and I really enjoyed stacking my shifts and having a big stretch of time off. And so that kind of sent me in the direction of doing locums. And so I was a travel nurse practitioner for the last probably 5 years of my NP career. Loved that aspect of it. I worked primarily up in remote Alaska, got some really good experience taking care of underserved populations. And then I thought, what am I going to do? Because that's not something that I wanted to do for forever. And I had some connections at one of my PRN jobs back in Texas. And if we didn't meet certain metrics in the ER, like so many intubations within a month, we would have to go down to the OR and get our intubations in. So we would stay, up to date on those skills. And so I got to talking with the CRNAs, shadowed some CRNAs, and thought, this is exactly what I want to do. And I purposefully left this out for now. So back in nursing school, I shadowed a CRNA and thought that's a possibility. I like that. But interestingly enough, at the time, I didn't have a good grasp of what CRNAs actually do and how easy they make it look when really it's not easy at all. And so, like most people, I'm like, this is kind of seems kind of boring, maybe not something that I want to do. After I got into medicine, into the ER and kind of the advanced practice side, I saw and realized that it's not easy and it's not boring at all. And everybody that says it's easy and boring, they're not in the field of anesthesia. So, I don't know what they're talking about. So I thought this is a reality that I want to do CRNA. I'm not married. I don't have any kids. This is the perfect time for me to do that. And so I thought, let me just try. Let me just see if I can do it. And so I applied to 2 different schools, National being one, and I got accepted. And I was like, this is a reality. I'm gonna do it. And so that's kind of how the transition happened for me. It was a little gradual. It was over the course of 8 years. I took the very long way to become a CRNA, but we're here now. So
Thank you for that. I feel like you did it all. You did it all.
I just took the long way around, man.
Oh, you were-
I'm a slow learner.
no, I was like, I'm gonna try this, and then I'm gonna do that, and then I'm gonna do that. You tasted it all. That's awesome. So you've been a nurse since 2012.
2012. Yeah, I graduated 2012.
Wow, that's a lot of experience, man.
Yeah, it flies by. I feel like I've been out maybe 2 or 3 years, and I look back and I'm like, man, it's been over 10 years now.
Okay, after we're done with this podcast, I want you to text me your skincare routine because you don't look older than I am. So
I appreciate that.
I want to know what's going on there. I think you kind of mentioned what I was what I was trying to bridge to my next portion. Next portion was like the decision making process. You kind of
Yeah.
talked a little bit about the key factors that you included. Well, I could ask you now that when you were picking those 2 schools that you applied
Mhm.
for, how did you do your research and how did you come about the program that you are in right now?
Sure, it's a really good question. So I will say from the outset, I really don't recommend my path for anybody. It's an extremely long, convoluted path. If that's something you're interested in, like go for it. If you want to work in both careers, go for it. But there are some things that I would change if I could that would have made this exponentially easier. And I say I really feel like I ended up at the best school for me. Um, and so at the particular time, I didn't have ICU experience. I haven't worked in the ICU. I've worked in emergency medicine, and that's where I got my critical care experience. And as most everybody listening to this podcast knows, you need really high acuity ICU experience to go to CRNA school. There are just a handful of schools that will consider high acuity ER experience like I had. And so that really limited me on where I could end up. However, looking back now, I really ended up at the best place for me. And I say that because as you know, there's such a huge focus on independent practice. I think we're in probably the best program in the nation for that. And that largely depends on your goals. If your goal is not to practice independently, if you want to practice in a restrictive ACT model, then this school's probably not for you. But if you want to practice at the top of your license and you want to provide really good anesthesia to high acuity patients across the spectrum, this is the place. And that's how I ended up here. I ended up at the best place possible for me. And I didn't know that at the time. But now that I'm here, I look back and I think, wow, this was the best. Even if I had all the ICU experience in the world, this would have been the place to end up for sure for me.
Looks like a match made in heaven, man.
Yeah, absolutely.
It was meant for you. It was meant for you.
Yeah, I
Wow,
got very lucky and very blessed to end up where I'm at now. So,
there you go, man. You put in the work. You put in the work. Let's put it that way.
yeah,
It all came out. It all came around well in the end.
for
So
sure.
another section I have is challenges and some expectations. So what were some of the challenges that you faced during this transition, and how did you experience as a nurse practitioner versus someone like me who's been an ICU nurse ever since, um, prepare you for CRNA school? So like different than me.
Sure. Yeah, that's a really
So,
good question. I honestly didn't really know what I was getting myself into when I first started. I'd been through a pretty rigorous master's program and had worked in, had been used to making my own decisions, making my own plans, treating patients. And so, dumb little me thought, how hard could this be? And so I just didn't know what I was really getting myself into. I knew it was going to be 3 years. I knew it was going to be a marathon, but really there was not much apart from school. There was really not much in my life that I had achieved long term, like 3 years out, with a goal in mind of working towards this endpoint. My master's program is 2 years, so I guess you can kind of consider that. But I really just didn't know what I was getting myself into. And so I knew, at the time that I was applying, there weren't a ton of resources out there. This was probably almost 3 years, 4 years ago now. There weren't a ton of resources out there. So I looked online for what I could find. There were some resources. And so I kind of did what I could to better my application. I had already taken a bunch of science courses. I had graduate level courses. I held like national certification as a nurse and as an NP. I'd published before. I'd sat on committees. So I kind of checked all the marks except for the ICU experience. That was kind of my rate limiting factor. And I knew like if I was going to apply and if the first cycle didn't work out for me, then I had a choice to make. Am I going to continue my current career? Am I going to go back and work in the ICU as an NP and try that, or kind of what the next steps were? And so those are all things kind of turning in my mind, thinking 2 to 3 steps ahead of what am I going to do next? And it was all overshadowed by the fact that I just didn't know what I was getting myself into as far as the rigor of CRNA school. And that's, looking back now, I just didn't have a clue. And I don't know that anybody does until you actually experience it.
I can speak to that as well. I can definitely speak to that as well. I feel
It
like
seems a very
no
common
matter
factor.
it's like no matter how much you think you're prepared for it, and then once you get into it and you're like, what?
Yeah,
What?
absolutely. Yeah, for sure.
It's literally like drinking water from a fire hydrant.
For sure.
It,
And it
it,
doesn't stop for
it
3 years.
stops for 3 years. That 3 years, that analogy fits perfectly. I feel like it's meant to be that way. You're supposed to. It,
Absolutely.
it prepares you. It prepares you to be ready for anything, I guess.
For sure.
So, for our viewers, can you describe typical day in your training settings? I know now that you're done with your didactics, you're done with 15 months of didactics. You're also done with about 15 months of clinicals. So you're like
Yeah.
at 30 months. So you're only left with 6 months of clinicals. So for those who don't know, National University is 15 months of didactics front loaded and then 21 months of straightly purely clinicals with some courses here and there. So you're almost done. So can you describe a typical day in your shoes, and also what are the most challenging and rewarding parts
Mhm.
of this journey, like currently perhaps?
Yeah, for sure. I think my clinical experience looks significantly different now than it did maybe a year ago. And so now, 6 months from graduation, I usually, depending on the day, will find out what my schedule looks like for the next day. So I'll find out what lineup I have. And at this point, I pretty much know kind of what anesthetic I'm going to provide for what procedure. If there's something that I see that I'm like, I haven't done that, I'm not quite sure what that looks like. I'll read up on it, and if it's a procedure, if it's something that I haven't done, I'll read up on it, see if there's anything pertinent that I need to know, and then at this point, I pretty much know kind of what anesthetic plan I'm going to do. And now that I'm at this point in my training, I'm trying different things. I'm trying things that maybe I haven't done before. So instead of doing gas generals on everybody, maybe I'll do a TIVA. Instead of using my preferred Miller tube blade, maybe I'll use a Mac 3 and try a bougie. Or maybe I'll use the glide scope and get really good with the glide scope. Or maybe I'll do an asleep fiber optic intubation and just try these skills that are really good to have in low pressure situations so that when you need them in a high pressure situation, you've done it before and you're good at it. Or using medications that I don't normally use. So maybe using a lot of ketamine or maybe using some Precedex, kind of titrating in different things that I wouldn't use on like an everyday basis. And so that's kind of where I'm at in my like anesthetic career right now, just trying those different things. And so I usually again find out my lineup usually the night before or sometimes the morning of. I'll get to the hospital usually 30 to 45 minutes early, get the room set up, go see the patient, pre-op the patient, see if there's anything that I need to know pertinent that would change my anesthetic. And then at this point, the CRNAs usually show up, 10 or 15 minutes before the case starts. I'll quickly discuss with them what my plan is. They may or may not show up on induction. I'll induce the patient, do the anesthetic. They're usually not there during the maintenance phase. They may or may not show up on emergency and extubation if it's somebody that's really sick or somebody that's really morbidly obese and this might cause some trouble. They'll show up and help. But otherwise, you're at this point in your training, you're pretty much doing everything solo. And if you have questions or you need some help, there are other people there, but you're pretty much running the show yourself. And so that's what we're going to be doing in 6 months. So 6 months away from graduation, you need to be doing that yourself. And the side I'm at now really is good about letting you be independent. That and focusing heavily on blocks. It's kind of the future of anesthesia. So we do a lot of regional anesthesia where I'm at right now. And so really fine tuning blocks, finding different methods to do blocks, getting ambidextrous, holding the ultrasound with both hands, driving the needle with both hands, those sort of things. That's what I'm working on right now.
Wow, I
That's
got
that's
great
a,
things.
a 30,000 foot overview of kind of where we're
Oh,
at right now.
yeah, I got great things to look forward to. But like, it sounds like you reached a comfortable point in
Yeah,
your clinical journey, and now you're pushing yourself to be a well-rounded CRNA, so you can be put into any situation. And I feel like it's the best time to learn when you're getting this education. This is the best time to learn and to put ourselves in those situations. So
absolutely.
thank you for mentioning that. Are you in Sholo currently?
I'm in Sholo, yeah.
Right on, right on, man.
So I
Okay.
will also say this at this point in your training, you need to be comfortable handling the emergencies yourself. Excuse me. So if you have an airway emergency, if your LMA stops working mid case, you're not getting tidal volumes, you have to intubate under the drapes, like embrace all of that because you want to do it now while you have somebody, 10 seconds away that can come in and help if they need versus doing this 6 months after you're graduated and you may be the solo provider somewhere. So really embrace those emergencies or those things that you aren't anticipating. And that just gets easier with time, honestly, the more you do it. And it doesn't happen every day. It kind of catches you off guard. You'll have a string of really good things and then something may go wrong. And it's just like, 1 second of sheer terror that you have to handle it. But I would say just embrace that because it's good to be in those situations now as a resident and have some help if you need it versus by yourself solo provider. You've never done it before and you're trying to figure it out.
I think that's a very, very, very good advice. Utilize the education to the best of its extent, so you're prepared for that. I often say like CRNA school is like, it seems like your job is so easy and chill on the outside, but like
Yeah,
the actual education is for that emergent time period, which could be a minute, 10 minutes, 30 minutes, or 30 seconds. I think that's what the 3 years prepare you for. So you put it very
absolutely.
nicely.
Absolutely.
So now we're going to talk about comparing your roles. So So I'm guessing you went to a nurse practitioner school, which was a master's degree of 2 years.
Correct. Yeah.
Okay, so how was your educational and clinical training different in terms of the structure, years of didactics, years of clinicals, comparing to a nurse practitioner and a CRNA, almost CRNA? And then also, could you also talk about the scope of
For
practice?
sure. Yeah, absolutely. That's a really good question and something that I think of frequently, actually. So in NP school, I'm trying to stretch my memory back to remember exactly what we did. I know we took our first quarter was like an evidence-based practice course, and then we did advanced pathophysiology, advanced pharmacology, and advanced physical assessment. And so those were kind of the intro courses that everybody, no matter what NP specialty you had, whether you were family or acute care or whatever, everybody took those core courses. And it was just kind of surface level, broad overview of, in pharmacology, especially, of like all the drugs, the antibiotics, the antihypertensives, all just surface level. And then in our physical assessment class, it was mainly like formulating differential diagnoses, ordering appropriate testing, working up patients for certain like disease processes. And then after that, we started our clinical sequence. It was much like national. Actually, we had a clinical course and then a didactic course. And so our clinical course, we would have like, I forgot how many hours we had to complete per like quarter or whatever, but we had clinical hours that we had to complete. And it was kind of largely, depending on what program you were in, it was kind of largely up to us what specialty we wanted to do. But we had to rotate through certain specialties. So we had to do like family medicine, OBGYN, internal medicine, emergency medicine, cardiology. We could pick specialties like cardiology or thoracic surgery or whatever, but there were certain core specialties we had to rotate through. And then in the clinical course, we had like weekly discussions. We would get on Zoom as a class and we would present patients and talk about the care of the patient. Um, and then in our didactic class, it was much like you would consider principles of anesthesia. You would learn, and we would pretty much go by body system. We would take like a body system and learn different pathologies, the pathophysiology, the signs and symptoms, to what testing would be indicated, what your differential diagnosis would be in somebody that presents with a certain chief complaint. And so, kind of broad level, it was very like wide in terms of scope. We covered a wide range of stuff, and but really only surface level. We didn't get down deep into the weeds, down to the cellular level of different pathologies. Sometimes we did, but not all the time. It was pretty surface level, but it was very wide. And then kind of comparing that to CRNA school, it's very narrow, a super narrow scope of practice, but it's miles deep. You go down to the cellular level with essentially every topic. And so that's kind of the rate limiting factor in the difference, is just the depth of information that you have to know, just because it's anesthesia only. It's not like you're doing cardiology and thoracic surgery and then dermatology and then pulmonology, and you're bouncing around between these different specialties. You've got one specialty, but you're going miles deep because you have to know every little detail about it. And so that's kind of the big difference, is just the depth of information. One is very wide and one is extremely narrow and very deep.
I agree. You put it very nicely. I can see that too in my education right now, that we talk about certain topics like I've learned them in nursing school in terms
Yeah.
of anatomy, physiology, pharmacology, even POA. When we put them all together, you really have to know deep at the very cellular level why this is this way. So it makes more sense. But yeah, it's we are the autonomic nervous system experts. We are our anesthesia only experts. So
Yeah.
that makes a lot of sense. Thanks for putting that so well, Lee. Another question I have is regarding your professional insights. Can you talk about some of the most memorable cases that really stood out to you as a nurse anesthesia resident?
Yeah, I think the most memorable cases to me are the ones where something goes wrong or where something comes up that's like unexpected and unanticipated. And so some examples of that would be, like a morbidly obese patient that they have an airway we're doing either like a sedation case or we're having LMA in, and they have some kind of airway problem mid case and you have to intubate under the drapes. The OB cases that are like crash C-sections, those really stand out to me just because those would happen super frequently. And for those cases, the patient is prepped and draped, drapes are hung, iodine's on the belly, the surgeon's there ready to go, and then we induce intubate under the drapes. And as soon as a tube is in, we say cut and they go. And so those cases are super memorable because they're very high stakes because everybody's looking at you while you're inducing. And as soon as a tube's in, they go. And then the higher acuity cases and the sicker patients kind of stand out to me. The XLAPs from ICU that we're transfusing, doing massive transfusion on, or hanging multiple pressors on. We have to do central line or art line mid case. Those cases stand out to me. It's really the things, the kind of the everyday things that you do. And a lot of anesthesia can become routine. But every case is different. And so there are things that stand out with every patient that may tweak your anesthetic one way or the other. And so it's not mundane, it's not routine, but it can look that way on the outside. Your 500th gallbladder that you've done, it can seem routine, but truly you have to be ready for whatever may come up in that case. And you don't know until you get there. You don't know what it's going to look like, and you have to be ready to manage everything. And so those are kind of the cases that stand out to me, the ones that there's something that unanticipated happens. And then some of the bigger cases, cardiovascular cases, those kind of stand out because those are just something that you don't do every single day. So those are the main things that stand out to me, honestly.
The way you mentioned it, how everyone is looking at you, that sounds like a lot of pressure. Changing that, changing that mindset where, as a registered nurse, we are taking orders, right, and we
Yeah.
take care of our patients on order basis. But now you're in this provider role where everyone is, all eyes are on you, and they're literally waiting on you.
Yeah,
That
absolutely.
sounds like a very stressful environment. Not only you are holding everyone, but like our actions can, like if we delay, it can affect the care of our patient because it can. It's if it's a true emergency, seconds matter. Wow.
Absolutely. Yeah, for sure. And I
Looking
would
for
say those quote mundane moments of where you're doing your 500th gallbladder, it's an easy airway and you're nailing the tube every time, that prepares you for the moment that you have something difficult come up. You've done,
yeah,
700 intubations on normal people or easy intubations, and then you get to that difficult one. You know what normal is. You'll be really good at knowing if something's abnormal and then troubleshooting and getting the tube in. And an airway is just an example. You could apply that to many different situations.
practice,
Absolutely.
practice.
Yeah.
Well, the next the next section was work-life balance, but I guess we can skip that because we don't have that. I'm just kidding. But how do you compare to you being a nurse anesthesia resident currently to when you were a nurse practitioner?
Honestly, the work-life balance, if you take out the school portion, if you take out studying for boards and doing our DNAP class and our DNAP project, it's quite similar, honestly. We're working a full-time job, plus we're doing doctoral work. So that kind of adds a whole other load. It's like working two full-time jobs. But the work-life balance would be much similar to a nurse practitioner, depending on what area you work in. There's so many different things you can do. You can work 8 to 5 Monday through Friday as a CRNA. You can work 8 to 5 Monday through Friday as an NP. You can work shift work as an NP. You can do shift work as a CRNA. You can do locums with either profession. You can stack your schedule however you want. You can do call. There are just so many options. And it's really dealer's choice. Whatever you want to do, you can make it happen. And so the work-life balance is strikingly similar. The only big difference I would say is if you're working as an NP in a specialty. So if you're in like a general surgery specialty or cardiology or family medicine, those patients follow you. You're going to be seeing the same people over and over, and you're essentially you take work with you wherever you go. And so that's a big downside to that. Whereas in anesthesia, once you're done with a day, you're done. And it's like emergency medicine as well. Once you're done with your shift, you're done. You leave it at work and you go home. And that's a plus, I would say, to anesthesia is you get to leave work at work when you're done. You don't have to take anything home with you. Patients aren't following you home. like they would if you were in a specialty where you're the primary care provider, or you're a specialty care provider, you're seeing patients over and over, you're following up on labs and imaging, that kind of stuff. So it's the work-life balance would be strikingly similar for CRNA and NP. As a nurse anesthesia resident, it's essentially non-existent. You have to create time for yourself and for your family, but it is what it is. We're 6 months out, so
Must be nice. I'm 6 months in. I got
it flies
30
by.
more
Don't worry.
30 more months to go. But it's the last part you talked about. So it's like much like comparing it to someone being a nurse. You clock out, you're done with your shift.
Absolutely,
Would
yeah.
you say that? Yeah.
Yeah, very similar.
And,
And honestly, some people like that, some people don't. Some people want to follow the same patients over and over, and if that's the career you want, that's available to you. It's
Mhm.
honestly what it is what you make it, and you could do whatever you like, which is really cool.
Any tips to manage that stress or
Yeah,
how you accommodate
yeah, a lot of
life?
tips actually. You got to manage yourself first. Like you got to take care of yourself. Uh, and I found that out kind of the hard way in didactic phase. I almost burned myself out a few times, but you really, really have to take time for yourself, and be healthy about it. I go to the gym several times a week. I run on the days that I'm not going to the gym, and that's really been good for me, for my mental health, for my physical health, and it's been really good overall to prioritize my self care. And that can be hard, when you've got a stack of stuff that has to be done by Friday or by tonight or whatever. Taking an hour, 30 minutes to an hour, whatever it is, to take time for yourself is super important. And to take time for the people that you care about, the people that are around you, your friends. And we're not talking about, taking a week off, but you can take time, you can carve some time out of each day to help yourself and to take care of yourself, and that's huge, especially over a 3-year time period. You have to be willing to do that.
Right on. Thank you for those tips. I'm also realizing that now. It is a lot.
Yeah,
You need family support around you as well, as much as
absolutely.
you if you have family, and if they're understanding it is a blessing, especially in this time. So moving forward, any advice for aspiring CRNAs or anyone who was in your shoes as a nurse practitioner who is considering this transition? Um, any specific skills or experience you recommend them that they obtain before making this switch?
Yeah, that's a really good question. So I would say have really like meet the bare minimum requirements. Obviously, have whatever school you're looking at meet those requirements, but just make sure that it's what you want to do. And the only way to really do that is to shadow. And even shadowing, it's hard to get a good sense of what's going on in the OR, just because any from experience, even from my preceptors, CRNAs make it look really, really easy, when in fact it's not easy at all. And so that creates the idea that this is really easy, really boring, and really mundane because you're doing the same thing over and over, but you're not. And it's hard to get a sense of that if you haven't been trained to do that. But I would still stand by the fact that shadowing really is the best way to determine if this is what you want to do or not. And so I would say shadow first and foremost before you go take classes, before you do anything else. Just determine, is this truly what I want to do? And again, it's hard to know because you haven't done it. But am I going to spend 3 years for nothing to absolutely hate the career? And you really have to find that motivation, because it's so easy in the thick of didactic. You're there now, you know how it is, to say, is it truly worth it? And you have to have something other than money in the back of your head to know that this is what I want to do, because the money thing will fade really fast when you're in the thick of didactic. So you have to have good motivation, and then again meet those minimum requirements. Um, and for really anybody, not just NPs in particular, if you want to go to CRNA school, just do your due diligence on the schools that you're applying to. I didn't really know anything about this before I applied. I assumed all CRNAs got the same training, and that couldn't be further from the truth. I tell people now The didactic phase of CRNA programs are pretty much the same. Like we're all taking the same standardized exams. We're all taking the C exam, the NCE. We all kind of have to know the same basic stuff. So didactic is strikingly similar. You're going to have different classes or different titles of classes for different things, but you're going to learn the same content over the course of, your didactic career. But really what sets schools apart is the clinical portion of the program. That's huge. And I didn't know that until I got into the clinical setting. And I'll give you some examples. So at my second clinical site, it was an independent CRNA only site. And there were some new residents from a different program, from a different state that showed up. And, the CRNAs were like, hey, just follow David for like a few hours. He'll get the room set up. You can kind of see how things flow. And so, I'm getting everything set up. And the nurse anesthesia residents, there were two of them from this program, specifically asked me who pushes the induction drugs on these patients. And I'm like, what do you mean who pushes them? Like, you're probably going to be the only person in the room because the CRNA is not going to be in there. So you're going to be doing everything. And, they're kind of like deer in the headlights. And so that's the clinical really sets everything apart. It all comes down to the fact, do you want to go to a school where you're in a heavily restricted environment and you're not going to learn to practice at the top of your license? You have maybe a 1 month regional rotation where you do 10 or 15 different blocks. Or do you want to go to a school where you can learn to function at the top of your license? You graduate. Yeah, I'm 6 months from graduation. I've got over 200 regional blocks, probably 20 central lines, probably 30 or 40 art lines, almost 1,000 cases. I mean, it's striking the difference between programs that put a high emphasis on ACT practice and medical direction practice versus schools that put a high emphasis on independent practice. And that's really where it comes down to. And the cool thing about going into an independent school is you can go work in any environment. If you want to go work in New York City in a restricted environment, you can totally do that. You're trained to do that. If you want to go work in rural Arizona and be the solo provider, you can also do that. And you can do blocks for days, whatever block you want to do. But if you graduate, if you go to a super restricted practice CRNA school, it's going to be really hard to go to an independent site and fly. It's going to take a lot of legwork. And so my advice is just know the school that you want to go to. And that's kind of hard to do, but there are resources out there. You can find out a little bit about the school. And if you want to work in those restricted environments, you have no desire to do independent practice, then that kind of settles the answer. But just know what you're getting yourself into whenever you interview at the schools and whenever you choose a school. That would be my biggest piece of advice, and something that I didn't know and I wish I had known. I just ended up in the right place for me, is what I can say.
I think the way I look at it is it's not just you. It's just not the schools which are shopping for the perfect applicant. It's the other way around too. Like
Absolutely.
as an applicant, as a nurse, you should also be shopping around for schools which fit what you're looking for. And what I'm looking for may not be what David is looking for, but David has a school which he's looking for. So it's like I think it's a good way to put it, like an equal trade. But
Absolutely, for sure.
thanks for the golden words. um, Future of anesthesia. How do you think the role of CRNAs is evolving in the next perhaps decade?
That's a good question. It's strikingly going towards independent CRNA practice or collaborative team practice. The days of the anesthesia care team are coming to an end. And it's not going to be forever over. If you want to live in a big metropolitan area, that's probably the environment that you will practice in. But if you want to live in medium small town, rural America, anything under like a million people in the population, independent anesthesia practice is where it's going. That combined with regional anesthesia, especially for your orthopedic procedures, the days of doing like general anesthetics and high opioids are really over for orthopedic procedures. You're going to be doing blocks on pretty much everything. And so in this particular market now, it's so easy to find a job and you can find a place that would train you how to do blocks. But in say in 5 years, the market settles down a little bit. People can be extremely selective on who they want. Are they going to hire somebody who already knows how to do regional anesthesia, or are they going to hire somebody who they need to teach how to do regional anesthesia? And there are resources out there to learn regional, but that's quickly where I think the future is headed. Um, the days of medical direction is so inefficient. It's the most inefficient model of anesthesia, where if we had every person trained to do anesthesia, if they were sitting behind the bag doing anesthesia, there wouldn't be a shortage of anesthesia providers. But that's unfortunately not the case. But yeah, it's quickly going to a collaborative model where everybody sits their own cases, or to an independent CRNA only model, depending on what part of the United States you're in. So being able to, again, practice at the top of your license, and that combined with the regional anesthesia, you're going to be golden.
Right on, right on. It's good to hear that we will have a job
Yeah,
once I
you're
graduate.
not gonna, you're not gonna have to worry about that.
Hopefully. All right.
You will be able to
Well,
choose where you want to go and how much you're going to make. Let's say that.
oh wow. Wow. I just want to be comfortable, man.
Yeah,
Just want to have a just want to have a good house in the countryside, family, maybe some horses. That'll be
absolutely.
life.
It's going to be a
But
reality.
yes, sir. Yes, sir. Yes, sir. We'll make it work. Last question before we conclude this podcast. Tell me a little bit about any kind of personal growth that you have, that you see yourself now, almost 3 years into this program. You look at David in the mirror from 3 years ago to David today.
Mm.
What's the big difference? And moving forward in future, have you considered a specialty, or what kind of anesthetic or what kind of anesthesia environment you want to work at? Ruler, ACT, like I'm pretty sure you have offers at this point, but
Yeah, really good question. So as far as the personal and professional growth, strikingly different. And it all comes down to self-discipline. I thought I was self-disciplined before I got into anesthesia school, and I was to an extent. But CRNA school really teaches you self-discipline, and if you don't have self-discipline, you will not succeed. Um, that's the biggest difference is the self-discipline. Really, it comes right down to, can you take care of what needs to be taken care of in the time frame that you're given, and manage everything else in life. And it's funny because CRNA kind of becomes the bar for every difficult thing you're going to do in your life. And so once you've made it through, you have something else come up, you're like, oh, you made it through CRNA school, like how hard can that be? And so CRNA school becomes the bar of which every difficult thing in your life will be set to. But self-discipline is the biggest factor by far, even now in the clinical setting. Self-discipline, studying for board, we're just 6 months out from taking boards, taking the NCE, and self-discipline to study every single day after clinical. And it kind of goes back to didactic. It's the same thing. Self-discipline to get up in the morning and grind it out, or go to the sim lab and grind it out. And that pays dividends whenever you get to a situation to where you need it. The self-discipline is just the biggest factor, I think, that I realize that I've made in the past 3 years. And it's something that honestly, it sticks with you. Once you've made it through the 3-year marathon, you're self-disciplined enough to really do anything you want. And it's a willpower, it's a power of the mind. And it's something that just slowly grows over time. It's not like one day you're not self-disciplined, the next day you are. It's a process, and it's hard, it's ugly, and it's just grinding it out when you don't want to. And that's what it comes down to. And that's the biggest change I see in myself, is the self-discipline.
it's a lifestyle.
It is. It absolutely is a
So
lifestyle, and it sticks with
it's
you. It doesn't go away.
it's a lifestyle. It definitely is. It's like when someone goes on a healthy diet. The
Yeah,
idea is to make it a lifestyle, so it can sustain it and you can live longer. So I feel like motivation fades, motivation comes and goes, but discipline stays. So
absolutely. And I will
so
say it,
thanks
it
for
it it pays off huge in the clinical setting, all of the self-discipline and all of the studying that you do, because everything clicks and you understand. And it's way more than memorization. It's truly understanding what drugs you're giving, what response you're looking for, and how that all comes together. And understanding that is really cool when you get to the clinical setting and you see it all come together. And there's these light bulb moments that everything clicks and you actually understand the physiology behind what you're doing, or the pathophysiology behind the patient and how you're going to manipulate that. And it's a really cool moment whenever those light bulbs go off, and you know then that everything is absolutely worth it.
Right on, man. So, what I was asking earlier, have you picked like where you're gonna work? What kind of
Oh yeah.
setting in the future?
So I don't know what I want to do as of yet. My goal is to do locums. That's where my heart is. I want to set my own schedule and I want to do what I want to do. So that's the goal. If I found the right full time job, I would absolutely take it in a heartbeat. I'm looking for something that would have either an independent or collaborative model where I can get a wide range of cases. I want to do some OB. I want to do a little bit of pediatrics. I want to do some adult medicine, adult surgery, adult anesthesia. I'm not super interested in like the specialty stuff. Like some vascular cases are cool. I'm not particularly interested in cardiovascular. That's not a specialty I really see myself doing full time. Um, but really, I want to go somewhere so I can get like a wide variety of cases and kind of practice the top of my license. That's really what I'm looking for.
A well cohesive answer. Well, I hope you find it place which is right for you. So before we
Absolutely.
conclude this, I'm going to do a rapid fire. But
Okay.
before I do a rapid fire, uh, give me an expression when you think of propofol.
An
Make an
ex-
expression. Any
an
kind of
ex-
expression when you think
an
of the.
expression when I think of propofol. I know after I give propofol, that I kind of get in my routine. I know that
Yeah,
as soon as I push propofol, that starts the routine of like what comes next, and it's just a matter of habit.
yeah. All right. So rapid fire questions.
Okay.
Rocuronium or succinylcholine?
Rock uranium now. I used to do sucks quite a bit initially when I started, but I do high dose rock now, especially at this site we have Sugamidex available. So I just do high dose rock if I have to RSI somebody, or just for if the patient needs paralysis.
So Gamadex is revolutionary. Now, and we
Yeah,
just learned about this with Dr. Wright this quarter. It's pretty great stuff.
yeah,
Um,
absolutely, huge difference.
yeah, Mac anesthesia versus Tiva.
Ooh, I like Tivas, man. Tivas are smooth. The wake ups are just chef's kiss. I love Tiva. I'll do a Tiva any day
Tiva.
over gas. It's a little more work, but yeah, a Tiva with some Dilaudid or some fentanyl or some ketamine. If you have Remy available, that's probably the smoothest. But yeah, Tiva all
Hmm.
the way.
Clinical portion of a CRNA school versus didactic portion.
Oh, clinical, hands down. Oh, the didactic was rough, man. You're in the thick of it now. Life gets better, let me tell you, though. It gets way better.
Looking forward to that. Kiddos versus adults.
Oh, that's hard. I love the kids. I really enjoyed pediatric anesthesia. That was probably some of my favorite cases I did, honestly. Very challenging airways on neonates, but if you can intubate a 2 week old, you can intubate anybody. But yeah,
Wow.
I love the peds. I would like to do more peds, but adults are fun too. I don't know. I guess if I had to choose one to do probably forever, I'd probably choose adults. It'd be hard to do kids forever.
Last question. I think I already know this answer, but Mac versus Miller.
Oh, Miller 2 all the way, man. Miller 2 all the
Oh,
way.
I knew it. I knew it.
You get
Well,
a
thank you
you
so
get a view every time with a Miller. You can't get a view every time with a Mac.
much, Miller. Well, I'm a very novice, but I like Miller too
Yeah,
as well. At this point, but
it's a little more
hey,
challenging to use. Mac, I still try. I do the Mac occasionally just to kind of keep up my skills. But if I know somebody might be challenging, Miller 2 is my blade that I'm going with.
right on, right on. Well, thank you so much for taking out your time. I know you're a very busy guy, and we've been working to find a day to find a date for this podcast for a hot minute now. So I'm glad it all worked out. But thank you so much for taking out your time, David.
Absolutely. Thank you so much for having me on. I really appreciate it. It was a good conversation.